All right, so my name is Ben Lewis, and today we're going to talk about inventory management. I'm a former HTM leader. We're testing boundaries here. I'm a former HTM leader with Honor Health, Novant Health, and some other organizations. I've started my own company, TechniHealth Solutions. We do focus on inventory software, so that's why I'm speaking about it. But it's really the basic, what I talk about is before the CMMS. I got some CMMS people in here, right? What data do you put in the CMMS, right? That's kind of what we want to talk about. So building an accurate plan. So to get it started, let's start asking some questions. Who owns the inventory at your organization? Who owns inventory in your organization? Does supply chain own it? Does finance own it? Do you own it? Who's responsible for an accurate inventory? Anyone want to answer? HTM, evaluate? Yeah. HTM. Yeah, from someone, right? Yeah. Now, one of the things about that, and this is a good question that we could probably talk about later, is if it's not on the HTM inventory, where else is it? You said complete and accurate inventory. So the CMMS is a maintenance. That's where you maintain devices, right? So imagine you're a hospital with outsourced maintenance, and is it in their CMMS? Are they handling it or are they not handling it, right? So that can be like, what's the source of truth? I see, we can talk about that if anyone wants to say what they're doing. I've seen where Oracle or their ERP becomes the source of truth and the CMMS is API'd into it. So yeah, there's different methods, but yeah, I agree that HTM owns, in the industry, in real life, when we get out there in the field, they're going to go to the HTM director for an accurate inventory of their medical devices, not the property book manager, right? So anybody, so we talked about that. What's your system of truth? Is everyone here is probably saying the CMMS. Is anybody disagreeing with the CMMS that that's not their system of truth? Okay, if you feel comfortable, hopefully this is a safe space. This is being recorded, but there's no cameras, actively, watching your hands right now. So, how many of you trust your inventory within 5%? Raise your hand. You trust your inventory accuracy within 5%. So we have one. Busy. Okay. What kind of inventory? Okay. Right. You did. Okay. You did too. All right. So a lot of people did not raise their hand, right? I think that's what's important. And so the people that did raise their hand or are raising their hand, one of the things I do want to hear from the people that aren't raising their hand, what's changed, right? So is the resources in the last 5 years post-COVID, right? Because you gentlemen right here probably haven't led since pre-COVID, right? And so post-COVID, are you seeing resource challenges for FTEs, right, to maintain an inventory? Are you having to do it smarter with less techs? Like, is that why that we're seeing other people saying we don't believe in the accuracy of our inventory within 5%? So, and then my follow-up question then is, if you don't believe that your inventory is accurate within 5%, that's 1 in 20, right? So does anyone have a family member that they want to put on a device, right, with a 1 in 20 chance of not being up to date? Besides, you might not like their mother-in-law, or raise your hand. I'm just kidding. Right. So this is an important inventory. If it's not an inventory, it's not being maintained, right? That puts you at risk, puts your hospital at risk, puts your patients at risk. So we want to talk about what is accuracy. What does an accurate inventory mean? Identify common failure points, build a baseline that's repeatable for your system, or talk about how to do that. Al, I'm going to be calling on you a lot because we got to have CMMS champ right here. Do anybody else? Do we have any other CMMS company? So Al's with a CMMS company. Anyone else? Right on. Does anyone else operate with a CMMS? Everyone else? Most people? Okay. All right. So how do you sustain accuracy? So I might be able to pay a jump team to come in, perform an inventory, right? Get me within 5%, but how am I going to keep it sustained? Let's talk about that. And what are you doing? And this is a conversation back and forth. I know usually I like to do it. If we have time at the end, I'll do it. I ask how many years of HTM experience you have. Last class was 250. years. Al's here, so we've got that beat. I'd like to see what that number is, but we'll get to it. So how do you sustain that accuracy, and how do you connect the importance of your inventory to the strategy of your organization, right? Am I buying, am I using this data to build my capital planning strategy, right? What's the difference? 10%. So if you buy a fleet of, there's a system I talked to not long ago, and they were buying IV pumps. It was a $50 million buy, right? If your IV pumps are 10% off, that's a big deal, right? So how do you connect that to the strategy of your organization? So if your inventory is wrong, that's kind of what I was just getting at. If your inventory is wrong, then every decision that you do make is going to be starting off from the wrong spot, right? It's going to be skewed. Your compliance, we don't probably need to get too deep into that. Al, I'm calling you real quick. Latest compliance inventory change. Anything new on PE 360 or anything you want to say about this compliance?
They still expect the same thing. They just refer to different,
right.
Different standards, but everything's the same.
Yeah. Okay. So it needs to be accurate, right? That's the base, and defensible, right? So. So your financial, we were talking about that earlier. Your financial missed assets. You're going to create purchasing plans. You're going to create service plans. I had at one point in my career, I used to call it eyeballs. Now you can use technology to do it. But hey, I'm about to sign this $3 million contract. I'm about to sign this $3 million contract. I really need all eyeballs on each one of these devices before we sign it. Now you can use technology for that. But talking about financial impact, see if we can get Lynn, can you grab the AV person and see? Sure.
So what the clinician is going to do about it, it's not, so like what are we and clearly articulate what is not enough.
Right.
Is an exam table a medical device? Sometimes it is, if it's wood or piece of furniture, it's not, right? So I think for that, where finance thinks everything is a medical device.
Sure.
I think we struggle a little bit on what we call.
I lean on defense, 510K approval for defense, right? Yeah. Does anyone else do anything different for like what you would define as a medical device? Is this medical or is this not? Does anybody have anything to add to that?
Well, I do think that for medical device, but I think not. But that's if you're in HTM. The rest of the organization, clinician, finance, all of this people don't understand.
Right. I would do things, I see your point. One of the things I would do is the language I would use is medical device and not biomedical equipment, right? That ties it to the department. So part of that is that language where you're speaking to finance and you're speaking to your leadership. So, biomedical equipment, I always felt that kind of landed it, like, oh, we own it. No, we maintain it, right? That's my stance, right? You have a sticker in your car, it says Cobblestone oil change. Cobblestone doesn't own that car, you own it. They just change the oil. That's my stance on the ownership of the device, right? We want in my opinion, your medical equipment is going to be better maintained if the user feels ownership of the device. Anyone add to that or? All right. Go ahead, please. Please.
Nurses do patient care, not equipment. So radiation therapy people do patient care. So I feel as though we own.
Sure. When you say care as a verb, I agree with you, right? When you're talking about equipment care as a verb, right? Yeah, so we do that, but I've seen a lot of damaged equipment, a lot of OR equipment flopped around, slapped around, lights, surgical lights smashed in each other. And if it was yours, what I do when I do new nurse orientation is I asked the nurses to treat the equipment like it's their cell phone, and they don't have coverage on it, right? You know what I'm saying? And so, you know, that's to me what I mean when I say ownership, you know, that you act like you're going to have it for 15 years because you may have it for 15 years, right? You know. Okay. So coverage decisions, when you're talking about the operational impact of your inventory, understanding what you have, how many you have, and how many you have available is very important for you to make those coverage decisions. So I like to use inventory accuracy and bring it into a system when we're looking at reducing cost of service, and say you have this many available, you've had this many incidents on the weekend, right? This is what it's costing you for that total amount of coverage from beginning to end. You know, you could have TNM'd this coverage out, but it's all going to be based on, did I have another room available, or did I have to go on standby when that cath lab went down, right? So accurate inventory is going to be really important. I'm not kidding. I've seen systems that find robots, and like literally robots, surgical robots in an inventory exercise, right? So you would not be surprised. You know, there's a lot of things that creep into your hospital that you don't know about. Right. So, you know, and systems that I've led, just like he said, it's going to be dependent on the hospital system. And systems that I led, yes, you put Biomed would inventory the server of the telemetry, right? The Philips, the GE server, etc. That would be inventory. But anyone not do that, you're going to have a cybersecurity problem if you don't. Yeah. All right. Let's see. We'll keep it rolling. Keep it pushing. Sorry about this. Okay, so what does a good inventory look like? Let's talk about that. That's what the slide that you'd be looking at says, if we can see it. There's several points on it. So what does a good inventory look like? It's compliant, right? So you feel, first of all, you're going to feel confident within 5% of that. You're going to have cybersecurity data points, MAC address. You're going to have your serial number. You're going to have your make and model pulled from some source, agreeable source, whether it's going to be ECRI, if you know, whatever you agree on for that is for your manufacturers and models. I can't remember what that slide said. You're going to not free text into your CMMS, right? So for me, that's the quickest. You know, a little bit old school, not as old school as Al, but a little bit old school. I can still do pivot tables. Brutal on you, man. Sorry, you were looking good yesterday, and you know, Jack. Pivot tables, like I can, if you just send, you know, Al and, you know, Joseph, I'm sure, and you know, other gentlemen in here that have run pivot tables before, and ladies who've run pivot tables before, in 5 minutes can see variation. You know, how many GE healthcare, GE dash healthcare systems, etc. do I have? Really locking that and keeping selections for your techs, and then, you know, having some kind of process for, you know, a variance that you have for some reason, right? So let's see if we touch those points on that discussion. So, you know, non-duplicated, what are you doing when you find a device? Well, I think one of the greatest injustices to the inventory, to a medical device inventory, was the movement to 100% PM completion can be managed. I think that hurt, you know, hurt our accuracy of inventory a lot. So, you know, back in the day, if you remember, you're, you know, out there tech, you know, you're tech going through trying to find 95%, right? You have to get to 95%. You're out there scouring, right? You remember? And then now it's managed, found, looked for, did not find. You know, looked for, did not find. You have some kind of process. So the number of devices, in my opinion, that I've seen that are out on the floor that are you know, and yeah, that are retired actually have really increased due to that change. It was good in intention, but in practice, I don't think it did the right thing. Right. Anybody disagree with that? So I think through technology like what we're talking about, the IoT, you know, poor man's RTLS, through real RTLS, through you're going to have computer vision coming out that's going to be able to read your asset tags as they roll by and tell you when the last time they saw it, you know, come by, or, you know, RFID. So with all of these things, I do think, that's going to be an opportunity to go moving on to sustainable workflows, right? So how are you going to sustain, but, I guess, and, I just said, I think that it hurt us, our inventory accuracy. These are the things that are going to help us get out of it, right? It's going to be the technology that we choose to implement and the policies and processes that we choose to implement, right? One of my favorite ones is to round until you're right, right? So you're rounding on percentage. If you think you have a 95% accurate inventory, I would challenge that and go out and look and see if you do. And if you don't, then round until you do, right? One of the things I like to do is to round a week before regulatory department rounds, right? That's a good way to kind of get a pulse, get a calendar, make sure you're touching everywhere they're touching, partner with them, and go in there and check the accuracy of your inventory. So the pillars of inventory accuracy are sustainment. So what are those ongoing workflows? Your reconciliation, what processes do you have from that? So like we just talked about when we opened up, biomed is likely, the source of truth for your inventory. How are you getting that to the people that need it and being a value to your organization? So is it going to be through your ERP? Where, how are you feeding that to your finance book, to your property book? That's going to be something you're going to want to look at. Validation verified against physical assets. So that's kind of what I think about when, what you have in your CMMS, that's interesting, right? What's really out there, and, again, my experience is anywhere from 65 to 85%. For those who said they felt confident within 5%, I don't see that out there in the real world right now, right? You may have seen it before. I'm not seeing it. I would love to know and meet the people that are that close, see what kind of resources they do and how we can replicate it. Standardization. Who are you standardizing to? Al, I am going to call both you gentlemen. I think you're in this space. Who are you seeing that people are choosing to reconcile to? ECRI. Yeah, I like that. To the level. Can you say that one more time for everyone? To the level of differentiate. What was it again?
Well, the level of differentiation is
where it brings value.
I have seen more people like we have customers in the UK, other areas across the pond that are moving more toward adopting GMDN. I think we're not there yet, but I would suggest that at a point where we do get there, the more you lean toward the FDA's versions, the UBI versions, that equipment will come with either barcodes or QR codes that when you scan it to enter it into your database, and it's already right.
Right.
Like I said, I don't think we're there yet, but we're headed in that direction.
Yeah, I'm going to challenge that in that, yes, that's the way of the future. We've got to get the manufacturers to submit that data correctly, right? You know what I'm saying? And you're also going to have a little bit something in between there from that system, because the manufacturers are identified by the actual physical plant. So there's like 6 physical plants from Philips, right? Those are going to show up. So there's some filter opportunity there. But yeah, I mean, I think that's very detailed, right? Using that, and you'll get a lot of models. So I agree with, there's going to be some type of, we need to filter that down to value, right? How many, do we really need?
Whatever you decide, standardize, take something, and if you just, so everything means the same thing, and then if at a point down the road you want to change, it's pretty easy to map to a different standard.
Sure. Standardization on location codes, kind of and identifying, knowing what assets exist where. Really want to open up to anybody that has any feedback on that, like, universal location schema. Where are my devices? When they're being tracked, where are they? Where are they? The ones that are stagnant and the ones that are being tracked. I'm seeing RFID as, no, not RFID, RTLS as well, RFID and RTLS. I'm sorry, I'm seeing RFID is a low cost choice that other people are starting to implement with their asset tags for future proofing, right? So that's, if I'm going to invest in the time to go out and do hopefully what we may decide to do when you leave this class is polish your inventory. I'm sorry, I got a side. Hey, no problem. It was good seeing you guys. Where's that at? If you're going to invest in polishing your inventory, and I lost it where I was at. Anybody, where was I at? Okay, let me keep going. Oh, universal location schema, RFID, RTLS. When you're going through and standardizing your inventory, is that the time to future-proof it, right? So if it's going to cost me 20 cents more, right, to put an RFID tag, asset tag on than not, do I see technology in the next 3 years, that I'm going to be able to utilize this? I think so, right? So that's an example of knowing what you have where. There's going to be other things we're talking about, computer vision that's going to just see your asset tag, right? And be able to tell you where you're at. And then that poor man's RTLS that we talked about. So knowing where you have it and how you build that into your CMMS is going to be important for your inventory. So where do they break down? We've been talking about some of these all along, right? Multiple sources of truth, whether it's your CMMS, whether you're outsourced, you're insourced, whether that outsourced company does maintenance on your OEM contracts, right? All of those things will, do you have one CMMS source of truth or 20? So that's important. That's usually that's one of the breakpoints. No intake or disposition process. So you're finding out that you just have 400 monitors on the dock that you didn't know about, right? There's a process opportunity and that kind of thing is going to cause you to have a non-accurate inventory. It can enter service, like I was talking about. We've seen robots, we've seen a lot of things in service that you just find, right? So entering service without a good intake and disposition process. So disposition, again, what do I have and is it here? Did I find it? And if I didn't find it, does it hold PHI? Like that's an inventory, an inventory question that you want to know. And if I have a piece of equipment that holds PHI that I can no longer find because I said manage, no longer, am I reporting that to a governance body? And what are they doing? Right? These are all important, and all of it's tied to inventory, right?
So two things. Listening to what actually happens, super important, right? We have leaders making decisions, the director of cardiology, bosses, and nobody's really talking because then logistics falls violent up. Right? So I think that's really important to hear what's happening at the facility so you can actually roadblock stuff. Because otherwise nobody has to do anything. And then also communicating that up, right? Like your senior leaders need to know, we had a robot that wasn't on our team for 6 months because Katie over here ordered it and nobody told us, right? I think you gotta be transparent about it.
Sure.
Ugly, but what ugly is saying.
Yeah.
I would echo that. The most successful we went out to do a PM. We flagged that had its own code in CMS. If we were called to do an initial inspection and it was already in the field, we hadn't seen it. That was flagged in the system. And we could report to the EOC incident by incident. Every department had to do that. That sort of public shaming got more people to follow the process when it came in and when it went out than anything else.
Right. Do you disagree with that, Chris? Because I also understand, as I was in one of my roles was a associate hospital administrator where I work with nursing, every day, and I do understand that nurses, what they do and don't do. But one of my arguments that I would give to nursing, kind of along these lines, are you're the last person in the fence. There's no one that I can put in between you and that medical device and that patient besides that nurse. So that's why, some people have stickers, some people don't. That's why I do have stickers, and that, I would ask the nurses, just take a peek at it before. Now, will they do it 100% of the time? No, and variability is risk. What's your opinion on that? It's important, yeah. Right. When you just said supply chain process problem, I just had an idea of a camera looking at your asset number as you cleaned them and sent it out, checking for accuracy. Is it in the inventory? Is it up to date? That's a process opportunity, right?
Like a license plate reader that a police officer uses.
Right.
Isn't that cool for us?
Yeah.
And the other thing that I'd like to mention is the IoT, IoT for connected devices. So we talked a little bit about that last night, where what I had, the integration that I had with my IoT, IoT and software was once the IoT, IoT software did not see that serial number in my CMMS or enterprise asset management, which is what I like to call it today. But once it didn't see that, it sent a message to my system administrator saying, "Hey, I see something on the network, and the serial number doesn't match, or but this is the device make model."
So you have a serial number that doesn't have an asset number to attach to, that flags a risk. That's nice. I like that. Anyone else doing that with their IoT?
Exploit your IoT, IoT.
Right on.
Don't not use it, right? You should be using that. If your hospital or health system made that investment, use it.
Right on.
The API integration is cheap.
Yeah. Great. And this is why I like doing classes like this, conversational. There's 1, 2, 3, 4, 5, and probably more people in this room that can talk to you about that conversation and how it can save you time. I know one study that they went up in the high 90%. They went from, like, I'm used to pre all of this technology, 90% on my IV pumps. It was really hard to hit 85 or 95% in a lot of the systems that I was working in. Now, with this type of technology, that's basically free, like you said, exploiting your IoT, you can move to high 90, they're experiencing high 90%, 98%, 99% on finding their devices. So yeah, and it's basically free. So these people over here that we've been talking to about that, definitely, if they're here all day, you can pick their brain on it. So building a baseline, the 5-step method, you're going to define scope. That was the first question I think that came out. What is a medical device, right? You're gonna do a field validation, which is important. Physical, what is actually there? I really think we've been seeing a lot of surprises. I have one customer that I did an inventory job with, and his comment was, after the first one, his comment said, "I'll eat your hat if you do better than 85% accuracy." Now, when I say accuracy, I'm talking about also accuracy of your PMs being up to date. So is it in the device? Yes or no? Is there a PM that's supposed to be done on it? Yes or no? Is it up to date in the system? And that's that accuracy number I'm talking about, being in the 65% to 85% range. And and I use that number because, one, it's the compliant one, but also, would you send your mom in there? Would you send your daughter in there, right? So I want to work that number up to as high of a percentage of accuracy and compliance I can. So eliminate free text, we talked about that. Moving to deduplicate models. I think that was some good knowledge Alan dropped on us, was to the, say it one more time for us, to value. It was you're going to deconstruct a value, or yeah, excellent, yeah. And you're going to reconcile that inventory. So I think I duplicated that. So build a tracking layer for new additions. I like what you were just saying, Al, about UDI coming in. You can actually get that information before you unbox it, commonly, right? Meaning it's on the outside of the box on most shipping now. So I mean, you can actually have a roll of assets, right? Scan your asset number, scan the UDI, and then unbox it, stick the asset on, and move that like that. So it's really, you should be able to remove a lot of finger clicking, with the technology that's out there today. Sorry, sir. I think we've pretty much covered all this. That without standardization, with standardization, you might have all of these variations of MX40 and TeleView, etc. I think when Lynn, you were talking earlier, I don't remember exactly what you're saying, but what I was thinking about was credibility. Like what you were talking about is, when you have all of this in line, right, you're able to go, like, how credible are you to the radiology director that calls you and you can't give them a good inventory, right? And how much more credible are you if you email them their inventory and recommendations, 3 months before capital planning season, right? And then how much more credible are you if you can go in there and give them every bit of data that they may want through validated inventory? So I think that's where all this, and this is with both finance, and influence is different in different organizations. Sometimes it's coming from finance, sometimes IT, supply chain, but aligning all of those, everyone's going to work better. All of their goals are going to be met with a better inventory. So sustainment, again, I hear people, I would say I agree that maybe you guys had 5%. Is it still 5%? Sustainment, right? I'm saying what's changed, new CMS, new leader. Let me tell you that one of the hardest times for me to hold a team accountable on inventory accuracy was when I had CMMS instability, right? I went to a new CMMS. I was having, first of the month, the PMs weren't going out. We weren't getting corrective maintenance on time. And so it was really hard for me to look at my team that was in the field doing everything that they could do and say, I want you to be better, right? But my CMMS was basically inoperable. So that's probably, just to be open and honest, that's probably the time in my career when the inventory that I was responsible for degraded the most, right? A CMMS that I couldn't hold anyone to account, right? I couldn't hold you to account for your closures, how many you left open, and then you're not working on inventory accuracy, and it can really get out of hand. So your job's really important, Alan, right? Yeah.
That is a big deal. You made a statement early on in the presentation. We're all being asked to do more with less. And if you have a product that is very difficult to use, and there's a lot of clicking, and it takes a lot of effort to get done what you're asking to do.
Right. Yeah, that's a way to drift. Exactly. So you could have a CMMS that works exactly the way it was designed, but it was poorly designed, right? And not get the biomeds to click on it. So I've got a developer, my partner. I've talked to him about the movie The Founder with Michael Keaton, where he's talking about McDonald's, how to reduce the amount of distance it took to create a burger. They laid it out on a basketball court, right? And I told him, that's what I want you to think about when you're building clicks. How far do they have to go? How many times do they have to click it? And that's gonna drive compliance for your team. We talked about cross-functional alignment. Did I miss anything? Your IT department, obviously, cybersecurity, what they purchase, finance, what they depreciate, it's all going to come out of inventory. Anyone have anything to add about that? Your COO is going to appreciate it. Again, credibility. There's one of the quickest ways to not have credibility is to not know what you're supposed to be taking care of, right? Oh, this is my biomed leader. He doesn't know what he has, right? That's a problem, Agreed. Yeah. I mean, I agree. I've been in organizations that had supply chain run property book, by asset, right? They were asked to run I've actually seen where there would be a property book number and a biomed asset number. I don't know how, that's a great idea, that's the best practice. Anybody doing anything better, like working with property book supply chain in here at all?
I've worked with it, but it never worked out because you also wind up with, if it's under 5,000, it's minor capital. By 10, it's major capital.
Right.
So you can look at an item and you don't know if it's the free one or the ones they paid for. And it doesn't matter from an HTM perspective, but it matters from a finance perspective.
And so this is the story of how we became the source of truth, right? For medical devices. That's absolutely. Anyone else doing any inventory outside of medical devices? Does anyone here have EVS or your furniture barcoded that you know about? Barcoded?
Just in our dialysis department.
Okay.
For the miners.
Yeah.
They want the dialysis department guys to maintain those.
Right. So that's location, variation, right? Departmental collaboration. Why? You as a leader, you hope you're going to want to have a leader that's going to kind of stick to that. That's why you stick that policy, and this is why, and this is what. There's going to be deviation, and hopefully, what I would ask the teams is, look at the values, the core values of the organization, right? And look at the core policy, and then go from there. There are going to be times where biomed's going to have to do something that's not. Anyone else taking, so dialysis, anyone else doing something in their inventory taken care of that may be a little bit off. I used to do low voltage communication, right, in biomed size.
The PA system in the
PA,
hospital.
yeah.
We have lots of that kind of stuff. We did the TV distribution.
TVs, I've seen that quite a bit. TVs, yeah.
Responsible for, like, we weren't responsible for the TV, we were responsible for the signal coming from the rack. But then facilities did all the TVs and swapped them.
Okay, that's
We
interesting.
started splitting things way too much.
Yeah. Now,
Which is
RO water, utilities, so ROs. Anyone doing ROs at their hospital that right now that you guys are doing ROs? Right on.
You know, but why would you do that, Chris? Why wouldn't you make it? Because I'm trying to leave a factor in my organization so that you know, try to manage people in the room, but I don't want fraudulent paramedics coming into my hospital and telling me they're gonna be better than my people, right?
Right.
Because I'm trying to leave stuff in there that they're not gonna do. They don't want to. I want to.
Right. Yes, there is. And I mean, knowing what I know about CHS, right, you're right, is you have rural hospitals, kind of smaller shops, right? And that forces, then you go meet a facilities director at a small rural hospital. He's the safety guy, the janitor, the, EMS guy and everything else. So biomed, I worked at a rural hospital when I worked at CHS 20 years ago. And I was part of the CERT team, like quick emergency response team. I was doing low voltage. You had to do more because there was less talent available, and it was 2.5-hour drive from Memphis to get talent in, right? So you became more independent. And so I do think, when you're in small facilities like that, you have more jobs, you wear more hats, right? And so you may have to go broader to what does biomed handle.
So whether we're doing cars or not, but they can choose that the more deviations you have on, well, in dialysis, we do recliners, but we don't do recliners over in the.
Right.
It just sends a chaotic message where they don't know, they'd rather, not put in a work order because they are not sure how to do it. Right?
Mhm.
And so I think that's where you have to get kind of really granular and say, if it has a biomed asset tag on it, it will be in your drop down, you'll be able to select it. If it doesn't, then you're not entering the right work order type. I know that's not practical, but at least that's just all like an 80-20, 90-10 rule.
Yeah, I've sparred with one of my leaders at a previous hospital that I worked with over that exact thing, exactly what you're talking about. She wanted to require the asset number, right? You know what I'm saying? And for me, I disagreed. Now, and the reason is again, it's that collaboration, kind of what Chris said. She's a nurse. My wife's a nurse. She come home. I haven't peed in 14 hours, right? You know what I'm saying? Right? And it gets really busy, right? So I didn't want to require but tell me. So that's why I say no. But this is important to have these conversations because some people say yes, and I could be wrong. So talk to me about what, again, for me, it's the leader. I want to look to the CNO and say, she was able to put it in, we'll figure it on the back. Oh, that's an IT device, we'll forward it to IT. We're not going to push it back to, and I know, you run an excellent program, I mean, I'm not saying that, but talk to me about that particular point and why that's better. Yeah, I don't think that it's not a right or wrong, it's kind of a culture, where are you at? Like, yeah, definitely. And Lynn and I have worked together in the past, and she usually wins 80% of the time. We call it a dance, like when she's disagreeing with me, and I'm like, come on. So yeah, I'm definitely open that I'm wrong in that. That's the way I feel is, I think you're going to have happier, not that their happiness is the most important thing, but you're going to have happier, more collaborative nurse directors when they find you easy to work with, right? So it's just kind of, but where are those guardrails that you set, right? I'm the dad that lets them do whatever they want to. I don't think you're the mom, you're the strict mom, right? So yeah, I mean, you got to figure out where those guardrails are. Mm-hmm.
Because again, it goes to say maybe IT, and they're like, oh, well, it needs to set a security ticket. So they close my ticket, and I don't even know they closed it.
Yeah, and it's challenging. People are changing software. They're changing, what they use every day. But You'd obviously want to have that workflow built in that you can do a warm handoff. There's probably going to have to be an API, depending if you and FM and, if you're all on the same, CMMS or not, it's going to matter. But I would say, and Al might have something to say to this because he's seen, all sides of that. You're going to be a happier customer. If I was Al, I would be trying to sell that integration immediately. I wouldn't want to go live with a customer that couldn't push a work order to facilities. But yeah. Lynn disagrees, I think, based on this conversation we just had. But yeah, I mean, it is kind of what are you running? Are you going to require them to follow protocol, right? You know what I'm saying? And get them into line, or are you going to say anything you throw out we'll handle, right? It is kind of, you got to figure it, it's a balance, kind of, and maybe this is where you do it, Chris. I know Chris doesn't like committees, but right, yes, but having a committee or having inventory as a committee bullet on somewhere, whether it's your medical equipment governance committee, whether it's in supply chain governance, of some committee where you're looking at devices, and then also knowing what happens when you hit that number. Right, so that's one of the most important policies, in my opinion, for you to agree with your leadership when you roll into an organization as a new leader. What happens when we change size, right? So if I get this many pieces of equipment, if I get this many locations, they're driving this many miles, come up with some formula, again, that you're basically agreeing that with this growth comes this support, right? And then for me, what I would do is if I can't get that support, I outsource it because the work's got to get done. Then I do, an SBAR, an RO on the ROI of re-insourcing, right? But yeah, so governance of your medical device inventory and what that means to you is important. Not only what is it, how accurate is it, but what does it mean when it changes? What does it mean when I lost a device? Again, that has HIPAA, that I said, man, look for, didn't find it, and it holds PHI. There's an action there. If you don't know what it is, I'll be at my booth at TechniHealth Solutions. I'm just kidding. Yeah. So it enables, compliance readiness. You're going to feel, again, credibility, compliance readiness, cost reduction, and knowing what you can buy. Has anyone ever ordered or had ordered a monitor set with the wrong SPO2, Nelcor instead of, right, Massimo? There's only two choices, right? You know what I'm saying? So having an accurate inventory, this is what's going to help you. We're almost at time. Again, capital planning. So credibility, finance, COO, IT, right? Chris, your IT your department's going to expect that you know what you have and are maintaining. And your operational efficiency. Do I have how many devices am I maintaining? Are they on AEM? Are they on AEM? What percentage of my fleet's on AEM? All important information and data that you can get from your inventory data. So actions that you can start tomorrow if you haven't. Most people in this room are squared away here, but eliminate free text manufacturer or model entry mode. No one, if you think that you should have that, I'd love to have that debate at my booth at TechniHealth Solutions outside. It changed my mind debate on that should be open. Identify your unknown asset gaps, reconcile that for modality end to end. So you can start with imaging. I'm doing an inventory project right now, and it's no ad. It doesn't really cost any more time. Hey, would you like pictures of your big iron rooms as we go through? We'll take anything that's a room. We'll start taking photos of it for you, and you'll be able to import that into your system too when you get ready to do capital planning. So then when you sit down with your radiology director, now you're really looking squared away, right? Implement basic intake control like we talked about, and then assign ownership of inventory governance. Who's responsible for that? I didn't hear anyone say anyone else was responsible but Biomed. Everyone said the Biomed was responsible. So it's most of the people that are in this room. So identifying who's responsible for it, and then what they're going to do to get there, and what they need. If you're a leader and you realize you don't have the personnel, right? What are you going to do? Are you going to use outside sources? You really owe it to your patient, to your community, to have an accurate inventory. I like to, when I was working at CHS, my son he's 23 now. I think he was 5 or 6. Had surgery in one of those rooms, and I was the biomed at this hospital, and I walked in. And I didn't have to take my hands out of, I didn't have pockets, I had scrubs on, but OR scrubs, but I was sitting there, I didn't have to touch anything. I said, okay, my son is coming in this room in 4 minutes, right? gas monitor, right? I'm looking at these devices and I don't have to do anything but go out and wait for him to come back in, right? And so if you know you have a good inventory, then you can feel good about your family and other patients going into your hospital and being seen. I think that's it. This is a link. This gets you to my LinkedIn if you'd like to link up there. That's probably the best way to get in touch with me. I do email too, but you can get it through there. I appreciate you attending the class. Thanks. Appreciate it.